Hello. Okay, everyone. Good afternoon. So I'll be starting this small topic. So I think it was a kind of an interesting topic. The more I delved into the later part, the SCAD, but the topic for discussion was microscopic colitis and segmental colitis associated with diverticular disease. If you look into any textbook or literature, there's not a lot of published articles on both of the topics, specifically SCAD. There are only 52 articles published in whole PubMed on SCAD. Well, microscopic colitis, there's a lot of stuff published. I'm going to start with microscopic colitis. So I'm going to go over definition, then briefly describe epidemiology and clinical presentation, then go over management. And there are two guidelines published to manage microscopic colitis. Then I'm going to go over a brief review of diverticular disease because diverticular disease itself is a very broad topic. And what I was allotted, the topic was segmental colitis associated with diverticular disease. So, how do we define microscopic colitis? So, I think the name is pretty much justifies the definition that there is no or little macroscopic inflammation, and the patient has chronic watery diarrhea, and you diagnose with only colonic biopsy. So it's at a microscopic level, and there should be no infectious etiology, and they need to be ruled out. And there is literally no endoscopic or radiological abnormality of colon. Well, this lately has been challenged because there was a recent study published, and they found that patients with collagenous and colitis has subtle ulcers, which were diagnosed with more advanced white light and NBI imaging technology, endoscopic technology. Generally, these patients have triad of chronic diarrhea, have almost normal colon, and histological pattern of either suggestive of lymphocytic colitis or collagenous colitis. I'm going to go over that. So um, it's generally present approximately in 10% of the cases of patients undergoing colonoscopy for evaluation of chronic diarrhea. Uh, Generally, it's present in patients of older age, around with mean age between 50 to 70. The incidence rates vary. The earlier studies have shown 21 to 24 cases, but in Europe, they say the incidence is approximately 11 per 100,000 patients. It's more common in female as compared to male, and this sex predilection is more defined for collagenous colitis than lymphocytic colitis. It's also more common in patients who are current smoking. Interestingly, there's no increase in mortality related to colon cancer or actually even adenoma, despite the fact that there is evidence of microscopic inflammation. In fact, one of a study published in Leeds University, Leeds in England, they say that actually the risk of adenomas and colon cancer was low in patients who have microscopic colitis. Okay, so how does it happen? We really don't know what's the exact etiology. Some of the postulated factors include exposure to luminal antigen and immune dysregulation. Um, uh, then dysbiosis, which is current hot topics, particularly the microbiome alteration, exposure to drugs, which is commonly tested for our board exams, and also genetic factors. So the lumen intelligent hypothesis was given by a group of researchers in Netherlands, and what they did was they actually gave gluten enema, and when they did sigmoidoscopy, and they found that there was lymphocytic colitis associated changes, and they found that, and also there is a clinical correlation since microscopic colitis is itself more associated with celiac disease. So they found that there is probably more exposure to antigen in the colon, which probably incites immune response. Then the other thing which supported this hypothesis was that whenever, for any reason, when the patient has a diversion of the fecal stream, there is a resolution of the histological changes. Again, they are very limited studies, and this is not a standard of practice until and unless patient have severe core disease to actually do surgery. Then altered microbiota. So there's a bacteria called Eckermansia, which I heard for the first time. And this bacteria is responsible for what we know as protective mucin layer. So this is actually marketed as also the bacteria promoting gut health, and the whole idea is it promotes a more it increases the turnover of the mucin cells. And whenever there is they did study to actually evaluate the microbiomes of the patients with microscopic colitis, and they found that the patient have less Acrosmania species, and what actually does with there is less mucin production when this bacteria is less, so there is more exposure to toxins or antigen, and they can easily enter inside the colon and therefore inside the microscopic immune response. Okay, and this was the study, and here I'm not sure whether you can see my mouse, but I think here you can see that the species this is Acromania species, they were significantly lower in microscopic colitis compared to this thing. I'm going to go over further because there's a recent article published in Clinical Gastroenterology and Hepatology just a couple of months ago, and they found a couple of other interesting bacteria which are probably also implicated in the etiopathogenesis of microscopic colitis. Okay, so this done. Now drugs. So well, this is
Hey,
commonly.
Haroon.
Oh, yes, Dr. Rubio.
No, it's
Oh,
Vivian.
hi, Vivian.
So
Sorry.
this bacteria, Akkermansia, can we test it?
No, we cannot. In fact, this is only in there is microbiome immune sensor Illuminas, which I think it's very expensive equipment. And I think Maine Virginia Tech has it. Maybe Dr. Wynn knows that because when he was trying to initiate the microbiome study, I could not find any available essays of in United States as far because I looked into this thing. I was like, this is interesting. I could not find it. Probably this is only available in research domain. Correct me and
Okay.
if there's any attending, because I looked into that because I was like, wow, this is interesting. And there's another bacteria I'm gonna go over, which I'm gonna say what's new in microscopic colitis, and maybe that would be interesting testing too. But as far as I'm aware, there's no commercially available assays.
Uh-huh.
Okay,
Okay. I
cool.
agree.
Yeah. Okay. So this we went over there. So now medications. So the interesting thing about medications is this was a study published which kind of correlated with all the evidence associated with drugs. So they commonly describe PPI, NSAID, and SSRI, and these are high likelihood. And one of the postulated hypotheses is PPI because of decrease in acid. There's dysbiosis, which probably relates to implicated one of the implicated factor for microscopic colitis. With NSAIDs use, there is damage mucosa and increased permeability, and the problem with all these drugs as a likelihood culprit agent in microscopic colitis is there's very few reports of re-challenged drug causing this medication, and this could be a mere chance association. But nevertheless, when and even if you in the guidelines you look into that, these are all expert consensus because there is no single prospective randomized control trial available whether you give the drug or remove the drug. Literally no, and this is both European guidelines and AGA guidelines, which was published in 2016. They both say that there is no like 100% evidence, and it could be just chance association. But a lot of the studies have actually implicated PPA, NSAID, and SSRI. And one of the comments in the author was, well, these diseases are generally present in elderly population above 60, and they have a lot of comorbidities. So the PPI can itself be just be, these patients are taking because they have comorbid heart disease or comorbid reflux disease, and hence they are taking because a lot of these people have comorbid arthritis. So they said like it's hard to prove, but still, if possible, just try to release stop these drugs which are implicated. And I think for the board purposes, PPI, NSAID, and SSRI are the most important drugs which they ask sometime in terms of association. Okay, so we are done with drugs. Now, pathology. So, genetics is not a major factor. There are two genome-wide association studies published in that. And interestingly, the only HLA haplotype they were able to identify was DQ2.5. Majority of the microscopic colitis research is done in England and Netherlands. And there is a Dr. Kane. He's a very like a researcher in Leeds University in England who did considerably amount of work on that, and they basically analyzed the whole genome of these patients with collagenous colitis, and they found that only actually DQ2.5, and again the results were conflicted when similar study was done in England and even in the United States. So they did not were not able to locate a specific loci. Then some researchers suggest that this collagen uh, present on the lamina propria could be all just a part of a normal repetitive process as we age or as our body gets injured. The normal inflammation is followed by collagen thickening, or it could be just a normal reparation process of healing of colon. And some patients who might have collagen synthesis disorder, they might express what we call as microscopic colitis. Again, this was refuted. Some of the researchers also did specific channel studies in the colon, and they found that there was defective absorption of monovalent ions, particularly sodium and chloride, which was responsible for causing diarrhea, and they suggested that there is primary defect in this in the ion channels. So again, these are all possible hypotheses, no concrete evidence related with this. I think the one of the most postulated hypotheses is there is evidence of microbial dysbiosis and immune dysregulation with increased mucosal permeability to luminal antigen, causing likely microscopic level injury. Now, what do we find when we do biopsy? So there are two kinds, lymphocytic and collagenous. In lymphocytic colitis, there is predominantly intraepithelial lymphocytosis, and it's defined as more than 20 per IEL per 100 surface epithelial cells. Now, this finding is very similar to resolving infection. So the guideline consensus and the expert consensus specifically state that this should be interpreted in the right clinical setting. For example, if patient has salmonella infection or any other infection, then you cannot label them as microscopic colitis. So stool cultures are prerequisite to rule out, because most of the patients with resolving infection or resolving ischemia can have similar pathological findings. And there is also some Paneth cell hyperplasia, decrease in goblet cell. The most important thing is there is because it's a chronic microscopic inflammations, neutrophils are present, but they're very rare, and there is minimal to no crib distortion, which is how we discriminate this from inflammatory bowel disease. So in collagenous colitis, the hallmark is there is increase in subepithelial collagen band more than 10 micrometers. So normal band is less than 5. Now 5 to 10 collagenous band or 10 to 15 lymphocytes, then they define it as indeterminate microscopic colitis. And what to do for that? The author said unless there is no symptoms, you just observe them. And one of the most important thing is that artifact factor should be taken into account, because when you cut the specimen in a different orientation, you can have artificial thickening of basement membrane, which might be reflected as collagenous colitis. I mean, this is something more for Dr. Greider to describe. I am only describing what the guideline states and what was described in the literature. So I'm going to go over some brief pictures. So here you can say that more than 20 per 100 epithelium fields, and specifically you can see that these are all concentrated around here. Um, and the crypts are fair or more or less normal in shape and size, and they're not distorted. And going forward, this is collagenous colitis, and here you can see that just from here is a thickened band of collagen more than 10 microcytes. There is lymphocytosis, but it's very less compared to lymphocytic colitis. And this is the collagen band, and when this stain with trichome stain, you can see this is all prominent fibrosis. Now between 5 to 10 micrometer, they say that depending upon the clinical context, you can label it that, but that's typically described as indeterminate microscopic colitis, which is a new clinical entity. Okay, so now where to obtain biopsies? So at least 14 studies are published on regarding the biopsy part, and none of them have said there's exactly 100% etiology. But what the study did prove that if the biopsy is limited to only rectum and rectosigmoid area, are shown to miss approximately 73 to 29% cases, specifically if you just limit to rectum. So the expert consensus state that you should do right and left sided biopsies. Um, but if you only do left-sided biopsy, that means up to the splenic flexure, there's a 99% chance you can catch all the microscopic colitis. A study which was published in 1990s, and they found that the transverse colon biopsy by itself has the highest yield if you just want to pick one segment of the colon. So based on the above findings, the current expert consensus guideline is you should definitely, I mean, there's a minimum rule of doing rectum biopsy. 8 biopsies should be taken, both for the combination of right and left side, and there is no clinical benefit or additional diagnostic yield if you separate them into different bottles. Okay, so we discussed biopsy, we discussed pathology. Now, clinical features. So the hallmark clinical feature is there is chronic watery non-bloody diarrhea, and patients have non-specific symptoms like abdominal pain, weight loss, arthralgia, IBS. A lot of these patients are diagnosed with irritable bowel syndrome before they eventually had colonoscopy and their diagnosis. And this is something new. I found a scoring system which has been described for monitoring the patient for microscopic colitis. It's called MCDAI, Microscopic Colitis Disease Activity Index. And what they proved, this was published in 2018, and this was a study cohort based on Mayo Clinic and University of California, San Diego, with Dr. Sanborn as senior author. And they weighted the each coefficient with the highest weightage giving to nocturnal and nocturnal stools and fecal urgency, and they found that the higher the score, the higher is the physician PGA index, which is physician global assessment scale. So, and they found that if there is any 1 unit decrease in the MCDI, it was associated with 9 unit increase in the quality of life. So they correlated this scoring system with the quality of life index, which is probably the most important determinant when to start aggressive therapy, which we're going to specifically go in detail. So this is something which was new to me. I never heard of that. Now, um, a couple of researchers, specifically from this is again Dr. Kane from the Leeds University, and what they found that can be on the basis of just physical signs and some certain factor can be devise a scoring system so that we don't have to do biopsies or have to do colonoscopy to make a diagnosis. So this scoring system was introduced in a study published in Clinical Gastroenterology and Hepatology in 2015, and they found that age, durations of diarrhea, number of bowel movements, BMI, smoking, SSRI, and NSAIDs. Interestingly, no PPI over here. And they found that if the score was more than 10, then likely this patient has microscopic colitis with almost sensitivity of 93% with a negative predictive value of 98%. And score of less 10%, you can avoid colonoscopy if the symptoms are mild. Well, this all study was done in patients from European cohorts, so the generalizability in American population is limited, but something to keep in mind. This is another interesting scoring system. Okay. Now, laboratory and endoscopic parameter. Generally, there is routine lab work is not helpful. Sometimes people have minor fecal leukocyte elevation. There's one study which actually used calprotectin to distinguish IBS from microscopic colitis, and generally in patient with microscopic colitis, the median level were 48 compared to 2 in IBS patient, which makes sense. There is still evidence of minimal inflammation. The two studies had one at 23 patients. The other study, even though there was a reference, I really could not find it. Maybe it was an abstract published in a meeting. So I mentioned about this thing. Even though it's the same macroscopic normal, there is a recent study published in 2017 which they found that with the better endoscopes and all that stuff, the patients with collagenous colitis have slightly more linear scarring and small ulceration. So they say that, oh, maybe 15 to 16% of the cases might have some evidence of macroscopic inflammation. So it's not just all microscopic, but this is something still more in the research setting. Okay. So now markers. So this is something new. I was just looking into data, like what are the antibodies or stool markers. So this is a very interesting review published a couple of years ago, and they found that none of these biomarkers are actually suggestive of diagnosis, but generally ANA antibodies are present in microscopic colitis, similar to what might be present in general population, but still like 20%, followed by anti-Saccharomyces cerevisiae and anti-thyroid peroxidase. But these are super low prevalence, and I think you cannot just make a diagnosis based on that, and it's more of an association. I would rather use this scoring system than these markers to actually check the disease. They have not been associated with any prognosis or any other clinical useful correlation with these antibodies. Now, what about the stool biomarkers? So these were all the stool biomarkers published and with all the different studies. And we can see that mostly neutrophilic and eosinophilic markers have slight elevation compared to healthy controls. So HC is healthy control. So generally, myeloperoxidase was slightly higher compared to healthy controls. Same as calprotectin with the median of 42, which I described in the previous study. Nobody has looked into fecal lactoferrin. This one study, which was done, which has only 21 patient, and they described there was just more positive versus no. There was no lactoferrin level. So this could be an area of research where we can look into all microscopic colitis patient and describe what's the median value. Given the fact that lactoferrin is cheaper than calprotectin, I think this could be an interesting area for potential research if we have to define a cutoff value for lactoferrin in microscopic colitis. Not a single study, then they only described positive and
Actually,
negative.
Varun,
Yes, Dr. Rubio.
I've been paying attention to the lactoferrin on patients with microscopic colitis, and they're usually in the 20-30 range.
That could be a good idea because it has not been published. There's not a single research published defining the cutoff for microscopic colitis. So, yeah, that's interesting finding of observation. 20, around 20. The same thing as.
20 to 30. Yeah.
Do you see more on lymphocytic or collagenous, or that we have not? That you're not sure
I,
exactly.
I haven't paid attention to that. It was just like I started looking at these patients when they have diarrhea and the lactoferrin is only slightly elevated. And when I do the colonoscopies, it's usually lymphocytic colitis.
Interesting. Yeah. So exactly like you pointed, very minimal
That would
data.
be something
Yeah.
easy to do study actually.
I agree. I agree. Very easy. You're right. Absolutely right. So, and only one study published where they did not even quantify it was just positive or negative, present or it's like same as fecal leukocyte, yes or no. So I think this would be something interesting. The other was eosinophil markers, which was again slightly elevated, but again none of these are like super suggestive of a particular disease or not. Then the other markers, tryptase, leukocyte markers, neuroendocrine markers, they are actually low or below normal compared to healthy controls. So I don't know what to make out of this, but this was an interesting article which I went over PubMed, and I thought it was worth sharing. And what are the fecal markers in elevation? Okay. And these were the tissue markers in microscopic colitis. So chromogramin, if present, it's higher in the left colon. These are tennesins, which are a marker of collagen tissues, collagen colitis, and then typhoid. Now, all these markers are more on the domain of the research, and I don't think so. We have special stains or special apparatus to actually check all these all these markers, and they are not clinically present the testing, and they're more in the research setting. Now, so After doing the fecal markers and tissue markers, so what's new? So the differential diagnosis, we have to make sure that the infection is raw. That's very important. Then you have to rule out if there's any acute colitis. So generally, the neutrophils are present in acute colitis with minimal or no intraepithelial lymphocytosis. So that's how you're going to differentiate if it's acute colitis versus chronic colitis, like with microscopic colitis. Then amyloidosis can be one of the culprits, and here there is predilection to the basement membrane and the blood vessel. And in IBD, there's script distortion, which is generally not present in microscopic colitis, and these are other etiologies just to keep in mind. I took this from DDSEP. I mean, DDSEP has literally 5 or 10 words about microscopic colitis. Now, management involves first establishing the diagnosis, generally with classic symptoms and colonoscopy. And you always rule out celiac disease in this patient because there is incidence of 3 to 4% in microscopic colitis compared to zero point 0.4 to 1% in the control. And this study was again done in England in Leeds University. Uh, you always review medication and removal of offending agents if possible. Then you exclude SIBO or bile acid diarrhea whenever there is other possibilities, just to make sure that these are not the factors causing those diarrhea. And if there is mild symptoms, you can start with over-the-counter, low risk medication, like after you've ruled out infections and all that, like antidiarrheal, loperamide, Lomotil. And if there's less response, you can start bismuth. But AGA recommends the first line should be budesonide. And now again, there is a lot of debate. Budesonide is very expensive. Some people have just 3 to 4 diarrhea. I have a patient which I just saw in the clinic, which I just saw a couple of I think weeks ago. He was has microscopic colitis on biopsy, but he has just 2 to 3 bowel movements per day, and he said, "I don't want to use any medication. All I care is over-the-counter Lomodil," and that actually serves him well. So I think here this more given limited evidence available, these are more like patient to patient basis and their preference. So if the patient doesn't what's the response of bismuth subsalicylate? Generally around 50 to 20% response depending upon how severe they have diarrhea. And for mild diarrhea, it's very effective. The only problem with bismuth is sometimes for more than 1 year of use, because these patients have chronic symptoms, can have neurotoxicity. The data for bismuth is only for 2 to 3 studies, and the largest study has 7 to 10 patients. So again, this was very, very kind of limited evidence, and that's what the guidelines also say. So if the refractory symptoms or the patient have severe symptom, then I think budesonide is the first line. And budesonide is the first line therapy just because it has high first pass metabolism in the liver, and it has very high affinity for mucosal GI tissues. And the randomized control trial, which was done with budesonide, they gave 9 milligram for induction therapy for 8 weeks, and it achieved remission in 80% rate compared to 26%. So this was one of a very high, good quality study, and therefore AGO recommends as a first line. So both European and American guidelines both recommend this as a first line. And you can see that the number needed to treat is just 2, so suggesting like great effect in terms of treatment of microscopic colitis. Now, what about budesonide versus mesalamine? Interestingly, AGO recommends mesalamine as a second line drug, but European guidelines say no, it's just more like a placebo effect or minimal effect. So AGA guidelines were published in 2016, and the European guidelines were published just 6 7 months ago in 2020. That being said, the data for mesalamine is just limited to case reports. So it's more like expert evidence. So I cannot make a comment. When I looked into the studies, these were all case series describing 4 to 5 patients. So AGO recommends second line if the budesonide doesn't work or the cost is prohibitive, because budesonides can be really, really expensive. And I'm sure anyone who has prescribed budesonide sometime has to go with prior auth. Now, relapse. Approximately 66% after the discontinuation experience relapse, and it could be 1 year later, 2 year later, a couple of years later, but sometimes they do experience relapse. And the predictors of relapse were the longer the duration of the symptoms and the severe diarrhea at baseline. So what to do if there is relapse? You can consider restarting low dose budesonide. So some researchers and some guidelines recommend starting at a 6 milligram per day compared to 9 milligram, and then slowly tapering it to 3 milligram per day, then 3 milligram every day, and so forth. Versus some researchers had just blast them with prednisone and see how what happens. There's some limited studies about immunomodulators and some experimental anti-TNF therapy versus surgery. So the things to keep in mind is if you're giving them budesonide, even though it has high first pass metabolism, but if you give them for 3 to 6 months, they can cause systematic toxicity. You have to monitor for diabetes, Cushingoid, and all that steroid-related side effect. If patients are true steroid refractory, which the definitions vary from European and American guidelines, some define as non-responsive to budesonide for 3 to 6 months, then you can consider thiopurines with 30 to 40% response rate on those patients who have actually failed budesonide. There are isolated case reports of vedolizumab and Remicade, and if none of these responds and they are disabling system, there are at least a couple of case reports, 3 or 4 published in PubMed, where diverting ileostomy with ileopaugeal anastomosis has been described. Okay, so well, generally they have good prognosis. There's no risk for colon cancer, and I pointed out that some studies suggest protective against adenoma and colorectal cancer. And there's no, if the patient is responding to medication, there's no need to do repeat colonoscopy to do proactive, reactive monitoring. This is in contrast to IBD, where after starting therapy, you might want to do repeat colonoscopy to see what how they are doing and along so forth. Okay, so I'm not going to go over this. Was I just listed some points over guidelines. So budesonide, if budesonide fail, mesalamine or bismuth subsalicate, they don't recommend uh, either probiotics or this treatment for Boswellia serrata. And this became popular in early 2000, but the study found that there was response of 44% versus 27% in placebo, and there were more side effects. So that's what say we don't recommend that. So it's very low quality of evidence and it's a conditional recommendation. Okay, and this is one of the flow chart. I think this described what I described in the text. So you patients have a lot of diarrhea. You start with stool bulking agent or antidiarrheal drug, no response. You can consider budesonide. If budesonide doesn't respond, you can start prednisolone. Now here the prednisolone is a little bit different. Why? Because the European guidelines don't recommend prednisolone at all, and they don't recommend even mesalamine. They said, oh, just repeat budesonide because of less side effects, and also because of limited high quality evidence favoring budesonide use compared to other drugs. Also, probably in Europe, the cost of budesonide is much cheaper as compared to the United States. So you have to take into account the cost factors into consideration. Now, if there's no response to these things, then you can start going to domain of immunomodulators or biologic therapy. And the only biologic therapy has been described is Vido and Remicade, with and immunomodulators being immune and 6-mercaptoprins. Again, these are just isolated case reports. And this was the European guidelines published, and here you can see that they don't mention mesalamine at all they mention is budesonides, and if doesn't wait, again budesonide, and then you can add loperamide or cholestyramine if the symptoms are mild, and that's pretty much it. And vedolizumab and infliximab or anti-TNF were the only kind of biologics which were described. Okay, so I think Dr. Moylan yesterday in tech meeting suggested that we should look into what's new rather than doing question. So just because the topic was interesting, and I think there's literally no mention of microscopic colitis in our DD-CEP curriculum, and even if you look into Schlesinger, there's only 5 to 10 pages describing microscopic colitis. So all this presentation which I presented is mostly from PubMed article search and other stuff. So I was like, let's look into what all has been published in the last 2 years. So there were at least 150 articles published. Majority of them were case reports, but the couple of articles published in major journals were this one. So they describe intestinal dysbiosis, and what here they found that uh, Haemophilus influenzae, uh, Veillonella parvulella, and Veillona species were significantly more abundant in microscopic colitis. I did not mention that graph over there. What interesting was a new bacteria, Elis types putridinus, had lower abundance, and the interesting thing about this bacteria is that this bacteria actually secretes butyric acid, and we all know that butyric acid has been implicated. Loss of butyric acid has been implicated in diversion colitis. So butyric acid has properties, and also nourishes the colon health and colonocytes. So, and they found that patients who have microscopic colitis, they have less in their stools, or in the microbiome, this was present less compared to the healthy control. And this also actually was correlated the fact that when they do metabolic pathway, they have more purine degradation pathway versus other synthesis pathway. It's a very interesting study and was published just 5 6 months ago, and actually it's still under, it says it ahead of press. So this was one interesting study which was published. The other interesting study which was published was what's the mortality in microscopic colitis. So there's no increase in mortality, and this was these kind of studies, mortality-related studies, are more easier to be done in Scandinavian countries because whole country shares one national database compared to United States, where different kind of database, and it's very hard to track all patients. So they found that there was no increase in mortality, even if there is any increase in mortality, which appears to be related to comorbidities rather than the disease itself. So, case reports, cholestyramine was, or bile acid sequestrant, sorry for the typo. They found that the patients who are not responding to budesonide and they were given cholestyramine for long term, 50% able to decrease of the budesonide and 20% actually stopped. So something to consider. Now, there were some isolated case reports of cannabis oil induced microscopic colitis, and this is a new biologic therapy for prostate cancer that induced microscopic colitis. And this was published just last month and in clinical gastroenterology and hepatology, and described vedolizumab therapy in refractory microscopic colitis, a single center experience. I could not read this article for some reason because it was not opening up, so maybe they're still indexing it or whatever the issue, but this was the only new therapy which has been described for management of microscopic colitis.